Good afternoon and welcome to today's Council on Black Health webinar entitled Addressing Weight Gain in Women of Childbearing Age, Lessons from a 20-Year Collaboration with the National Home Visiting Organization. Today's webinar is the first in the Spring 2020 webinar series offered by the Council's Solution to Diabetes in Black Americans Core. This core is part of the NIH-funded Center for Diabetes Translation Research at the Washington University in St. Louis. The Solutions to Diabetes in Black Americans Core provides methodological and content expertise to advance the field of diabetes research in Black Americans. My name is Tiffany Eaton. I am a doctoral candidate and research assistant at the Dornsife School of Public Health at Drexel University, where the Council is based, working with Dr. Shariki Kumanika, the founding chair of the Council. I will be your moderator today. We really appreciate you joining us during these especially challenging times. The Council's mission is to develop and promote solutions that achieve healthy Black communities. We leverage the credibility and perspectives of Black American researchers, other collaborators, and research partners to facilitate relevant, community-engaged, actionable solutions that positively impact Black communities. Today's session will discuss weight gain in women of childbearing age. Young adulthood is a period of high risk for excessive weight gain and development of obesity due to pregnancy and postpartum weight retention. During the presentation, we ask that you post questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our presenter to respond to after the presentation. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to also use the chat window to interact with fellow attendees during the session this afternoon. Today's presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email. Our esteemed speaker today is Dr. Deborah Haire-Joshu. Dr. Haire-Joshu is a scholar of health behavior who develops population-wide interventions to reduce obesity and prevent diabetes, particularly among underserved women and children. She is the Joyce Wood Professor of Public Health and Medicine at Washington University in St. Louis, and is the director of the Center for Obesity Prevention and Policy Research and of the NIH-funded Center for Diabetes Translation Research, the co-host of this webinar, addressing health equity among rural American Indian, Alaskan Native, and African American populations. Dr. Haire-Joshu has over 25 years of experience developing and leading numerous large-scale national NIH trials addressing the prevention of obesity in diverse populations. Her most recent research focuses on interventions embedded within the routine practice of a national home visiting program, which can be scaled to prevent excessive weight gain among diverse high-risk women of childbearing age. Dr. Haire-Joshu, I now invite you to proceed.
Thank you very much for attending the webinar. I was very pleased when Shariki asked me to do this, and especially in these challenging times, I'm very happy that others could join in as well. I wanted to talk today about some of the work that I've done over the past couple of decades, and it's been really related to partnership. Primarily, I'll talk about one which has been through a home visiting organization I've worked with, but more importantly, I wanted to talk a little bit about how important these partnerships are as we move forward in addressing issues related to obesity and chronic disease and real-world kinds of interventions. So I thought I'd set the stage a little bit for the kind of the overview of the talk. And the first is to talk a little bit about obesity and overweight as a chronic disease epidemic. And in these days of COVID, obviously we've got the acute epidemic, pandemic, which is really occupying, as it should, most of our time and energy. Obesity and overweight have been a slow-moving, deadly epidemic. So at opposite ends of the time spectrum, if you will, but nonetheless very critical. I want to talk a little bit about changing targets of how we address the prevention of chronic disease by preventing obesity as a disease, to talk a little bit about the efficacious interventions that we have that can reduce weight and delay weight regain, and as importantly, spend most of my time talking about what we need to do now to disseminate, implement, and really scale up these evidence-based interventions and really put them into the real world where they'll have effect. So just as an overview from what we all know around adult obesity, these are our latest figures, and we have about half the country is obese, as you can see from the first graph there, and this is by gender and race, but overall about half the country is obese, and if you add your overweight to that, we're looking at 70 to 80% depending on race and ethnicity. We know that men, the Hispanic men make up the largest group in terms of men and in terms of obesity, although white and African American men are not that far behind. And we know that 57%, almost 50% of Black women are obese in adulthood. And so these are really kind of staggering figures, especially when you consider the level of overweight and the movement towards obesity as people age. So we focused on children with good reason, and these are just data, recent data related to childhood obesity. And you can see that as of now, in 12 to 19-year-olds, there's almost 21% are obese, and there's another group that are overweight. So really, they develop it from the age of 2. We see the increases. And then again, we see the racial ethnic differences, primarily with Hispanic and Black populations bearing the brunt of childhood obesity. So for good reason, most of the past couple of decades was focused on preventing childhood obesity. There was a lot of good reasons. Policies pursued that. People were going to be much more amenable to change around their children than they were around their adult behaviors. They wanted a better life for their children. They wanted their children to be healthy. And so for a lot of reasons, much of our work is focused on preventing childhood obesity, all good things. There's been many advances made policy-wise, many programs, and obviously the First Lady, Michelle Obama, had done a whole lot around Let's Move to bring to the forefront prevention of childhood obesity. But we still, when we really look at it, there's still disparities over life course transitions. We know that there's a twofold increase in obesity from childhood to adulthood, which has really been ignored because we've been so focused on children. And so when you look at an 18-year-old, by the time they're 30, 35, they've moved into obesity. And you can see here we run into the same kind of disparities, especially pronounced in the Black population amongst women, which we saw from the prior slide. So if we want to reverse the obesity epidemic, a lot of what I focused on in the past several years has been looking at young women, and they're a target group to really focus on. Bill Dietz had a really nice paper a couple of years ago that said that, you know, we needed to refocus our efforts, these young women, especially as they become parents. We need to really step in and control this weight gain that they were having to not move them into chronic disease at young ages. We know that there's an average annual weight gain of the population of 0.5 to 1 kilogram a year. So that's 1 to 2 pounds. And if you have these young women entering adulthood, even if they're overweight or near overweight, and by the time they've gained over 10 to 20 years, 10 to 20 pounds or more, they move into overweight and or obesity. So it's a very vulnerable time for them. A lot of this is because they're childbearing. And with each pregnancy, they gain weight and probably retain weight. A lot of it is they're taking care of other folks, they're working, they're doing other things, and weight creeps up a little bit at a time. So we also know that young women are less likely to benefit from some of the interventions we have because they are busy. They're doing a lot of things. So if we think about what's out there for them and how that works, there's a great example of an efficacious intervention and who attends it, and that's the diabetes prevention program. So I just want to spend a few minutes on this because it's kind of the state-of-the-art role model program for moving an efficacious trial into other settings. And as many of you know, the diabetes prevention program, which really ended in early 2000 because it was so effective, discovered that the lifestyle intervention to prevent or delay diabetes worked better than metformin and the usual care and reduced by 58% diabetes incidence in high-risk groups. We also know that it was a very intensive intervention done with a diverse sample, but the first 16 sessions were weekly and you had coaches and contact and supervised instruction, and then there was another 6 months of bi-weekly sessions, and then it really even went on after that with some monthly contact, less rigid. And there were specific sessions with an hour and a half that had to be developed or had to be implemented. So it was a very structured, it was an excellent clinical trial. And what we see is that to bring it to scale, the original study was in 2002, and then there were 92 people who participated in the study. Ron Ackerman and others did, that showed that it was effective in YMCAs, and then there was some online movement to move it to online, which worked, and it was the same intervention pretty much. They had done some of the Veterans Administration, and then they moved it to a national diabetes program that was going to reach everybody. This National Diabetes Program to date has had, it's probably a little over 14,000 now, because this is data from 2017, and they've had more groups that have participated. But if you look, let's assume it's even 20,000 people, you have 86 million people with prediabetes, and many of them are going to develop diabetes in the next 5 years. So the program requires partnerships with public-private organizations, required approved curriculum, requires all of those things. You have to have a program that can deliver for at least a year. You have to submit data, you have to have trained coaches, and you have to have designated individuals to coordinate. A lot of requirements that are not going to work well with less capable organizations that have more stressors. So if we look at the reach and we get back to our young women, thinking about them in particular, the reach into, this graph shows the 20% is how many eligible participants currently do the diabetes program, the National Diabetes Program, that fall into the young adult age range. And 28% of those who participate in less than 4 sessions, which is how many it takes to really do something, 28% of the 20% who participate in that age group attend too few sessions to make a difference. So we have a program that's not reaching a high-risk target group. So what that means is that we have a chronic disease epidemic. We have young women in particular, young adulthood, but especially young women who aren't getting uptake or not reached to efficacious interventions that can reduce or delay weight gain. So what that means is we have to find a way to have that reach this high-risk group in ways that are relevant to them. So this began about, it's probably been more than 20 years ago. I come out of the clinical trial world, and I was very concerned just clinically in practice seeing young women 40 years old coming in with diabetes, coming in with chronic disease. Many times were in neighborhoods of poverty. Many times were African-American women who faced tremendous stressors because of the environmental circumstances, and that they were not benefiting at all from a lot of the work that we were doing in the clinical trials. And this was something that resonated in particular with me and many of my colleagues. How do we address the social determinants? How do we address and have these things that we're doing reach the population that most needs it, and not contribute to disparities? And in many cases, many of us have worked with schools and work sites, communities, and healthcare to try to develop these interventions. And all of these have a place, but they hadn't shown particular success in working with this group. And so I stumbled upon home settings as one place where, gosh, the women don't have to go out to go to a meeting. They don't have to drag children with them. It's in the home. It's where people spend a great deal of their time. Maybe there's something that can be relevant there. So in looking at partnerships with home visiting organizations, they're available, they're accessible. Usually they're affordable, sometimes free, they're convenient, and they had reach. So all of those things bode well for using this as a partner, a potential partner. And the interesting thing was too, they're there to meet family priorities. Now that presents some challenges when you're trying to layer other things on it, but they're there for family priorities, they're addressing essential needs, and they have reinforcement and support for families over time. They're usually there over time. But the challenges are that they're outside of healthcare. So their mission is not obesity or nutrition necessarily. They have another mission. They have criteria they have to meet for reimbursement that has nothing to do with something like a DPP. And it becomes a question of, can you include the content or adapt the content in a way that it's going to make a difference? So this is when I said to many of my colleagues, you talk about the luck. I just happened to stumble across, I guess, the Parents as Teachers National Home Visiting Organization, because I had many young colleagues who kept raving about this organization that came to their home, and they had young children and made them feel so good, and it just was all about child development and parenting, and it just sounded like this great organization. And their mission is to promote early child development. They're not healthcare. They're strictly promote child development and support engaged parents. They have a standard curricula for trainings. Their national center was here in St. Louis, which was great because that's where I am. And they train parent educators on the standard curriculum. They are there from prenatal until the child enters school, so you have consistency. They have 25 visits a year, so that means that you've got some kind of contact, ongoing contact and support. They're free to parents, and usually that's through state and federal funds, and it varies a little bit by state as to how much coverage, but they typically, they are free for parents. Next. They have sites across the country, and they also are international. And they serve a lot of parents, a lot of children. The numbers go up and down, but they're pretty consistent. They've been as high as 250,000 parents. And so but it's always pretty stable. And they're diverse. And so for me, looking at this, I thought, here's an infrastructure, it's regular contact, it's support, it's all these things that we try to do. It brings an intervention to the parents. How can I work with this group? This group sounds wonderful. And this was their national network. And by the time I look at their national network, I say all the time that I was drooling with what can we do? This is like something that is meant for a partnership to try and work to really integrate a lot of the science that we have. So this began a long-term partnership with them that our first funding was in 1997. And this is the series of projects that have taken place over the years. And I want to talk about the first 3 together as what I call the add-on projects, where I was really learning and feeling my way as to what is really a partnership about. And the next 2 are the health grant, which I'll talk about separately because it's got a whole separate efficacious and D&I approach, and then the Life Moms grant, which is probably my smarter decades of work, I'll say. So the first phase was the add-on phase. And this is when I literally picked up the phone. I look back now and think, gosh darn, I guess I was really young and I'm not sure what I was, but I picked up the phone because I'd heard they were great. And I had this idea, and NIH had an announcement out saying we need to do improved diets, in particular of African-American adults, because there was such disparities in the dietary quality and content. And I called them and went and talked to parents as teachers, and they weren't interested in the science. They were interested in helping their families. They are very much dedicated to their families and those children, but they knew that nutrition was important, and they were concerned, especially with their low-income families, about some of the diet they were seeing. So they wanted help with that to fit within their program. So after several times, we got this grant to look at dietary intervention for the African-American parents to do a culturally relevant diet intervention. We worked with over 700 African-American parents who had infants. All the children were under a year of age. And when I first did it, I started doing with, okay, we're going to basically take what we knew from science and behavior and add on a whole bunch of content, and got it down to about 5 visits, if you will, of core content. And at one point I look back now and think I was trying to do mini dietitians, and I worked with the parent educators, but I don't know that I listened as well, and they were probably trying to figure me out too. But we managed. We did a really nice intervention. It was an additional 5 visits and an improved dietary outcomes. And lo and behold, it was so successful that we got money to, at that time, dissemination was a CD-ROM. And so we got the CD-ROM and moved it to a CD-ROM. And lo and behold, Jackie Joyner-Kersee, who was an Olympic star, is an Olympic star, she had a foundation in East St. Louis, and we picked up the phone. I can't believe we did this now, and called her, and she said, I'll come over. And she filmed an intro to the CD-ROM. She was so excited about having something around nutrition for Black mothers and children, and came over one day and filmed it like 3 different times till she got it right and almost missed a plane because she was going to DC for some big honor. Just amazing. We disseminated over 1,000 CD-ROMs. We just sent them out through parents as teachers, and over the year we had about half adopted them. And that was what we knew about that curriculum. Is still running around today, I think. And then I said, well, what about we can look and see if parents change their behavior, what about children? And so PAT said this time, you know what, we don't have anything for our rural families in Missouri. We got nothing. And so we'll do it again. Can we do something different? We have a literacy program. Can we make it about literacy and change and meet the needs of this rural group? So we looked at what the rural group, what kinds of foods they ate, what their challenges were, and we got some funding to do another intervention to look at parent-child change. And we were looking at fruit and vegetable in really, really rural areas of Missouri. We worked with about 1,300 parents and children, and we did again, this time I added on visits again with their input, but we did it a little differently. It was like a transition, and I think we did it more around literacy. They had a lot more input into the intervention, and we had targeted books for the children, who many of them had never had a book with their name on it, for example. So they had a lot of input. And we saw a change in fruit and vegetable consumption, and not only that, the home environment improved, and when parents changed their behavior, the child behavior improved. So very telling data that came about. This was packaged, and PAT put it on their website and did annual trainings with their parent educators around it, and that was how we disseminated it. And then the third one, which was our learning curve with add-on, was the balance intervention, which this one was, well, they had a postpartum teen program, very, very high-risk teens, had almost no intervention around nutrition, no curriculum around nutrition, and NIH was interested in working with high-risk groups and obesity. These young girls were very at risk for obesity due to postpartum weight retention, and many of them, our youngest was 13, many of them at 15 were having second children. And so very high-risk groups. So we worked to develop curriculum. Some of it was new, and some of it was integrated into their home visits. So we started to really look at how we could move the intervention into their practice better and not make it so separate. And we did very, very simple patterns. We didn't try to do, we didn't try to do a whole lot of nutrition stuff that they weren't going to understand. We did around very, very high risk patterns that resonated with teens, did a group randomized design nationally over 30 states with over 1,300 teens. They were on average about 17, 18 years old. By 12 months, 89% had maintained a normal BMI, which was excellent because there was so much weight gain, or they improved their BMI. We had improved dietary patterns again. But we didn't see a sustained change at 24 months, in part because we lost a lot of the young ladies because they became pregnant again, or in some cases, they were a very mobile population, but we had seen 1 year. So that's kind of the add-on piece. And it was a transition over really a decade or so of work, many times with the same people. The organization was changing some. They were starting to understand what could benefit from research for their families. And I was listening to them a little better, I think. And that led us to our second phase. And this is where I think the partnership really took hold in many ways. And this one, it became about embedding the content within practice. And with this, we got funding from NIDDK to adapt the DPP into the Parents as Teachers group. And we focused on St. Louis. We met extensively with the educators to develop a curriculum that took the DPP and moved it into their regular kinds of practice, their regular home visiting. We targeted overweight or obese women who also had children who were borderline or were already classified as overweight or obese, and did a 24-month intervention to see if we could impact their weight. There was 8 hours of training with 10 educators, and it turned out that the educators this time, they picked what they did. They picked when they gave the assignment, as they did in usual practice. If someone had needs of social determinants, if they had something else going on, many times they didn't cover what would have been in the lesson. They waited, and they delivered it as the family needed it, which I have to tell you was a little hard sometimes to wrap my head around, but it worked. Their average length of visit was the same as usual care. It had very good fidelity. We had taped some visits, and we had on-site evaluations, and the participants were generally very satisfied. Yes. And so these are just some of the baseline characteristics. These women were around 32, 33. Again, they were primarily overweight or obese, 2/3 obese, I believe. And we had a somewhat diverse sample, primarily 39, it was about 42% overall were African American. Generally, they were a fairly high WIC group, fairly low poverty and low household income. And what we saw was we were able, after 24 months, we saw changes in food in terms of how much sugar and calories and portion size and sugar sweetened beverages. And we saw change in physical activity, not the first 12 months. We saw change in physical activity from 12 to 24 months. And we saw 5% weight loss, which was our goal, at 24 months. So it took 2 years to get there, and we saw a reduction in waist circumference. But this was what was the really telling graph. Because if you look at the data at 1 year, we had around a 5-pound difference, which wasn't, it was significant, but it wasn't clinically astounding, and was certainly below where the DPP was at 1 year. But then you look at 2 years, and what we saw at 2 years was that our women continued, the women in the health intervention continued to lose weight. It was gradual, it was consistent. It really trusted that the parent educators were delivering the intervention as they saw fit. And the other group was gaining, as we know tends to happen with the routine annual weight gain. And so it kept improving. And it was so exciting to see that, because what it showed was that, first of all, you trust your partners to deliver the intervention as they need to within their practice. But secondly, that by really simplifying information, delivering it over time and supporting it, you were having a really pronounced effect that took longer, but that's because the intervention was being delivered over time. And as my colleague Rachel Tabak says, Parents as Teachers is really a social determinant organization. So in many ways, it was a social determinant intervention that we were kind of integrating ourselves into, but they did social determinants and what the family needed first. And we came as they were able, the family was able to handle it. So it was very exciting. And this was the maternal waist circumference, which also showed, certainly this decreases cardiovascular risk, which was a wonderful clinical finding. But again, we saw 12 months, there was a difference, and it just kept going. They were losing weight, but the other group was gaining weight. So very interesting to see. So this trial then, that was wonderful data. And luckily I worked with some wonderful dissemination implementation people at Washington University. And so Rachel Tabak took the lead on and is PI of this Health D&I national trial, which is really integrating health across the PAT system in a way so much more sophisticated than we've been able to do it before. It should really help to advance empirically what happens when you disseminate a trial. And it's pragmatic group randomized trial. It's in 28 sites across all of these states. It's looking at the impact and the effect of the trial, not only on weight, but on acceptability, appropriateness, how it was adapted, the context within which it was delivered. So we'll learn a lot about where it works, where it doesn't work as well, how it works, all those questions that we've been unable to answer so far, and see how it translates to national practice. So really excited. And this trial is just now starting its second year. And the second trial that I just wanted to talk about briefly was the Life Moms trial. And this one, as I mentioned, we know that weight gain in our young women occurs during pregnancy and postpartum. Well, pregnancy, of course, then retention postpartum is a major risk factor. And that the childbearing years in particular are when you see young women picking up weight so much, very, very disproportionately. And the excess weight gain, which I didn't show those data, but the excess weight gain is really tremendous amongst various ethnic groups, and pregnancy puts young women at very high risk for that. So we wanted to target that and see if there was some way that we could address this as a very high risk factor. So we participated in the Lifestyle Intervention for Expectant Moms trial. It was a consortium trial that just recently ended, funded by NIDDK, NHLBI, NICHD. I think everybody in NIH just about funded it. And it was designed to really see what happens when you control gestational weight gain, but also had as a secondary aim for most of the sites looking at postpartum weight. And it was interesting because there were originally 7 sites, and we all did our own interventions, and we all had our own participants. We didn't share, we didn't have one intervention like you have with many of the clinical trials. We developed our own. So we had interventions that were packaged foods for 9 months. We had interventions that were apps, and we had routine clinical trial interventions. Our intervention was the home visiting and partnering with parents as teachers. We were the only ones who opted for a community partner, but it was really, really because of the true belief that that's the only way we're going to have an intervention that is sustainable or makes a difference, at least from my perspective and that of my colleagues. And I had worked on this with Sam Klein and Allison Cahill and some of the others. So this is, it was a very unique kind of consortium group. So our group, again, we worked with pregnant African-American women who were overweight or obese. They primarily lived in the north side of St. Louis, which has very high poverty, high crime areas, which is evident from some of these demographics. Over half were single, and over 90% qualified for a variety of mechanisms because of poverty. During the 4 months we worked with them, over half of them had moved once and 12% had moved twice while they were pregnant. And they lived in very, very high crime areas. The usual care, all of them got prenatal clinical care, the traditional care that people get with monthly, bi-monthly visits. And then we did something a little different. The usual care included the PAT visits. And so PAT had just a kind of a pregnancy curriculum, which was really about safety with baby and a little bit about breastfeeding, but nothing extraordinarily different from that. And we took that and embedded some lifestyle change concepts into it, just like we had done with the health grant. And this one in particular, we worked exceptionally closely with the parent educators who knew the population well. And there were 10 prenatal visits and 12 postpartum visits. So our parent educators had about 6 hours of training. They, unlike the other groups, which had very, very standard protocols, ours was flexible. The parent educators would schedule and get in with the moms, but again, they would walk into a home, and if they didn't want to do the nutrition because there was something else going on, they didn't. And I would add that during this time was during the time of the Michael Brown shooting and the tremendous amount of rioting that we had. And while all of these visits were going on, the educators and the moms would call them and meet them other places, or the moms were trying to get moved. There were many other things going on, and those things were handled with the educators and the families, and that meant the intervention waited. We had a mean number of visits that were equivalent across usual care and PAT. We called it PAT plus. And pretty much there was a little difference in time, but not tremendously. And there was, we taped the visits, so we have a lot of tapes of what went on. These are some of the baseline characteristics. Generally young sample, BMI again, obese, generally obese, about a third were overweight. And they were primarily Medicaid patients. So this was the results. And we had our gestational weight gain difference, which was significant. I would say our clinicians were not overly thrilled with that difference, but the interesting thing was that our intervention did exactly the same as the intervention with the moms who got packaged foods. It did exactly the same as the moms who had the app, and it did exactly the same as those who did the more clinic-based kind of interventions, which was always diverse samples. We had significant change in weight by week and by guidelines, and change in body fat. But then we get to the postpartum weight, and the postpartum weight was really, really interesting. So again, 12 months out, and we saw a significant difference in the number of women in our group that returned to baseline weight. And we saw the same pattern, if you will. This is baseline to gestational weight gain right before they had the child, their baby. And then this is the end of the line is 12 months postpartum. And what we had here was about a 7-pound difference. In health, obviously after 12 months, or 24 months, it was about a 10-pound difference. But we see, of course, these women had a baby in there, but we see the same kind of pattern of the significant difference between the two groups. And this was, again, part of the routine practice of PAT. They're seeing their mothers regularly. They're introducing core content over time as the mothers were able to handle it, and we see the same pattern. So we were very excited and decided that this was an efficacious intervention that had real world effect. And we wanted to see if it also had real world effect if we actually disseminated it nationally. And so we worked with parents as teachers to do that. So again, Rachel Tabak, myself, and many of our original team who are wonderful, submitted, and we've got this pragmatic cluster randomized trial now that NIDDK is funding to look at this again. What happens when you take this national? What happens when we have pregnant women participating in PAT, really getting this intervention so much, again, I'll say social determinant intervention that happens to do nutrition and lifestyle. What's going to happen if we take that national with a very, very diverse group? So again, Rachel is the D&I expert, and we've got so many of this is implementation outcomes, and that's going to be looked at very carefully. I'm excited to look at how this intervention is adapted by sites and some of the measures we'll have around that, and to look again at the context. We're going to have a very, very diverse sample. We're going to learn what our PAT sites think. We're going to learn how it affects them and how it affects their patterns of change. There's just a wealth of information to see how this efficacious intervention can move into a real world setting in a real world way. So in conclusion, I think that obviously we want to expand our efforts, at least in my view, to prevent obesity. I think the only way we do that is by partnering with these organizations that are not necessarily healthcare, but they're organizations that work in the real world, that reach the groups and the populations that otherwise we can't reach. And that partnership, I think for me, it's been a learning curve. I've learned a ton about how to think about working with real world partners. I've learned a ton about trusting what they do, from my early days of here's the science and we need to put in as is, to really the adaptation and the practice, respecting that practice-based research and research-based practice, to really look at that and value that, and now with our D&I grants to try to measure that and how that works. It's critically important. I think if we adapt these interventions, we can do a better job of bringing science to scale, but we have to be able to adapt them. We can't drop them in on top of an organization, which isn't funded to do it. Anyway, not funded to do it. They're not evaluated on doing it. We have to work within their world to make the intervention work so that it fits for them. The way Parents as Teachers has done it, it's paid for through their regular mechanisms. It's paid for as part of their routine home visit. And so it's not, except for additional training, it doesn't really cost them anything extra. That doesn't always work that way. When we did the add-on interventions, that had to be separate. It was added on, and so the funders weren't going to pay for something that wasn't about child development in particular. By working with them and partnering with them, it makes the intervention fit so that it could be covered. But the other piece that meant is that you have to respect that they deliver the intervention in accordance with their expert practice, which meant in many cases they weren't doing, you've got to get this time portion control, or you've got to do 30 minutes of exercise, or that wasn't it. They walked in the house and they decided what the family needed. And so you had to trust that. And that means that long-term follow-up is sometimes needed to capture what goes on here and to capture any differences. If you do 12 months, I said many times at 12 months, I would look at the data and go, oh no, oh my gosh, this just isn't doing what I had thought it would do. But you look at 24 months and it's great, because it takes longer because of the way it's being delivered. You track all that, and we need to look at all that, and these D&I grants will look at that. We'll look at how that's gone on and how it's been done. But you need more time than the traditional grant to get those changes, and you have to trust that that will happen if you have an efficacious intervention. So on that note, I would be happy to take questions. I'm not exactly sure how I'll get the questions because I can't hear anybody, but I would be happy to try and answer questions if I can get them on chat or and any other way. Okay, I think I do have a question. So I am going to go ahead and read the question, and then I will answer it. Can you expand on your insights for how to successfully partner and maintain partnership with home visiting organizations? I'm especially curious about home visiting organizations that may have different characteristics, be operating in different communities, and have different funding structures. So what I found in working with parents as teachers, which I completely didn't pay a whole lot of mind to at first, mainly because I just wasn't as much aware of it. All the constraints they had around what their funders required them to do and the evaluation criteria they had to meet. It took me a little bit I had to really listen and figure out what it was they needed and how the interventions, how the science I was bringing to the table would fit within the requirements they had around their funders. They were really driven in so many ways. They couldn't have their program if they're not funded, and their funders, depending on the state, had different requirements for how many visits or what needed to be in those visits or how those visits needed to tie to child development. So in terms of just the parents as teachers, every site is a little different. Every site had slightly different criteria. They had certainly met parents as teachers criteria, but sometimes they had other criteria. And so in terms of maintaining the partnership, it was really over time trying to listen exceptionally carefully to what their requirements were, how they had to have those requirements met, and coming up with a way that what I was offering could meet their requirements. So for example, when we did the High Five for Kids program, the reason that was done was because parents as teachers had a rural population that they were not meeting the needs for. They didn't have what they felt was adequate curriculum, certainly around nutrition or other things to meet those needs. And they had a literacy program that had very few resources. And this was many years ago. And so we came to the table with, well, maybe that's how we incorporate our intervention, and that's how this will work. And it can still then be funded through your routine mechanisms. And so it was really listening to them, what their requirements were, and coming up with a way that whatever I did would meet their requirements. So it was a win-win for them. First win for them and a second win for me. So I don't know if that answers your question exactly, but that to me was the key. And that was probably the biggest thing that I learned as I went on with time. Okay, and another question, I'm curious, how is PAT adapting in the current climate requiring social distancing? They have converted, a great number of their visits have been converted to online. And obviously that is some challenges for some of their families that don't have as much internet access. So I'm sure some of the families aren't getting the visits in the same way they were before. But they were pretty facile with converting. They've actually been doing some work to do online visiting. I think our data has shown that that it's pretty clear that if you get one home visit, that sets the stage for the rest of the relationship, one personal home visit. And so I'm thinking that probably most of these families have had some, already know their educators, so it makes it a little easier for them to do online, but that's what they have been engaged in primarily. I have another question. And this is, can you say more about your team? What are the characteristics of the wonderful team? So some of the folks who've been working with me, who have been working with me for at least 20 years now. And I have the members of my team have primarily been Cindy Schwartz, who's worked with me. She's an RD MPH and has just an exceptionally calm person who is able to read situations very clearly and talk about somebody who listens, really understands educators and organizations, as well as diet and real world diet. We work with some parent educators who have worked with us now for many years. Some are just amazing. They worked with parents as teachers. They joined our team on some of the studies because they were dedicated to nutrition. One of them, Ronnie Berth, has been with us now for about 6 years, and she is amazing. knows the families, knows how to incorporate nutrition, but always puts her families first, and has dealt with any number of social circumstances before she's actually delivered the science, if you will, of the nutrition intervention. So really understands families and understands context in a very practice-oriented way. We've been lucky to have many of the educators who joined us who do that as well. I also have academic colleagues that I mentioned who are experts in nutrition. Rachel Tabak's PhD RD and has extensive D&I experience. Epidemiologist, worked with Ross Brownson, who helped us design our initial studies. I mean, it's really, for me, has been, I always like to say I'm a passenger with a bunch of really sharp drivers. But they filled in the research piece, the science piece in really rigorous ways around research design, around nutrition, around D&I. And then on a practice side, really had the privilege of working with some of these educators who you kind of sit in a room and watch them and realize how little, at least from my perspective, how little I really knew about real world practice. With the way they interact with the families and build relationships with the families, and are so dedicated to the health and well-being of their families. So, so yeah, a very diverse team who knows their community and knows their science. And what advice do you have for scholars who would like to engage in this type of work? Can junior scholars take on this level of community engagement? I would say, you know, in terms of working in the community, when I look back, some of it was I was driven by a mission. I really was driven by the desire to do some better science than I was doing, or have better impact, I guess. And listening to the folks around me and trying to learn about the community around me and what might be available. I had a lot of fails along the way, I guess. I mean, I had a lot of times I reached out and didn't work, but I would certainly encourage scholars to engage in this kind of work. It doesn't, you're not, you know, it's funny because this is really good science. It's really good science. I've been on every end of it now with clinical trial work, which is wonderful. And this is wonderful. It's a different kind of work, which is really, in my way, so impactful in a very meaningful way. And I do think junior scholars can take on level of community engagement. I always think it's nice. I worked with so many people who were already engaged in the community. I watched them, I learned from them. And in some cases, I was introduced to different groups by them. And so I think anytime you can, team science is really important here. Anytime you can work with others who have community contacts, to work with others who are doing community projects, to learn from them, to get started, that I think that it's very, very, very effective. So I certainly think it's important to do, and that junior scholars should engage in it. It takes time, but it works. And clinical trials take time, but then they end. Not always, but you know, they don't really end, but parts of them end. I think this is a way of continuing it, so. Let's see, and then can you talk a bit about how you established your rapport and the ways in which you maintained the relationship for such a long time? Yeah, it's interesting. If you had told me in 1996 when I made that call that I would still be working with them in 2020 and probably in 2024, I wouldn't have, no, I would have never, ever thought that. I don't know how that happened, but when I looked back, the first project led to this next question. The next question, your first project was, we changed parent behavior in very trying circumstances, and we were able to have effect. Well, what happens if we change parent behavior? What happens to that child? That was the second question. And then the second question really looked at, you know, we started with like 30-year-old parents and then went to younger parents, and then I was looking at teen parents. It was like everything led to the next question, and the next question was informed by the agency. They would come and say, you know, we have these teen parents. We don't have any kind of intervention really we're doing with them, and gosh, they're young parents, and they really they've got these young babies they're taking care of, and we feel like we need more from them. So many times the next question was informed by the partner. And I think what happened was over time, they benefited, they knew of the benefit that they were getting from working with me. And certainly I had benefited tremendously from working with them. And so even though I had worked with other organizations, I kept going back to them. It just seemed like we were in sync, and I just really loved their infrastructure and the way I could reach out. Even now we do it with the D&I grants, we do it very empirically, but previously it was reaching out in a different way, which CD-ROMs or anything else. But I think for them, they were getting something out of it. They were helping their families, and that's what they wanted. And they wanted to do it science-based. And it just evolved over time. It was a lot of growth and it was a lot of learning, but it evolved. But hopefully they always got something out of it.
I thank Dr. Haire-Joshu for the wonderful presentation on addressing weight gain in women of childbearing age, and even giving the insightful perspective on the lessons learned from the long-standing academic partnership with national home visiting organizations. Also, my apologies again for the technical difficulties, and thank you all attendees for your patience with us this afternoon. On behalf of the Council on Black Health and the Solutions to Diabetes in Black Americans Core, I would also like to thank our attendees for participating in today's webinar. We'll share an evaluation survey and video of this webinar shortly. Please look out for an invitation to our next webinar on Wednesday, April 29th, entitled Expanding Healthy Food Retails in Black Communities, a review of strategies and their public health impact, and that will be presented by Dr. Chelsea Singleton. So have a pleasant and safe afternoon, everyone. Take care.